Welcome to LexCura Clinical Insights, the podcast where clinical evidence, healthcare standards, and litigation strategy come together. I'm Michelle Carroll, founder and chief clinical strategist of LexCura Summit. Critical care nursing is one of the highest stakes areas in healthcare. ICU records are dense, technical, and often difficult for non-clinicians to interpret, but they contain the minute-by-minute evidence of what the care team knew when the patient began to deteriorate, and how or whether the team responded. Arterial line trends, ventilator settings, hourly assessments, severity scores, medication changes, provider notifications, and escalation records all contribute to the clinical picture. When the patient deteriorates and the nursing record contains a significant gap in assessment, monitoring, or communication, that gap may become central to the liability analysis. In this episode, I will explain ICU documentation standards, show you how to read the critical care record, and identify failures in recognition and escalation that may support a negligence and causation argument. How about this for a thought? The ICU is one of the most advanced places in modern medicine, yet some of its biggest failures come down to something as simple as communication. Today, we're diving into how ICU documentation and failure to escalate care can lead to life or death consequences, and sometimes legal battles.
That's such a striking way to frame it. When you think about the ICU, you picture cutting-edge technology, highly trained professionals, and rapid decision-making. But it's true, none of that matters if the right information doesn't get to the right person at the right time.
Exactly. And what's wild is that the stakes couldn't be higher. We're talking about patients who are already in critical condition. If there's a breakdown in communication or documentation, it's not just a clerical error. It can have devastating consequences. And when things go wrong, those medical records become the centerpiece of investigations, lawsuits, and even public scrutiny.
Right. And that's where the dual purpose of ICU documentation comes into play. On one hand, it's a clinical tool meant to ensure continuity of care. But on the other hand, it's also a legal document that could be scrutinized in court. Those two purposes don't always align perfectly, do they?
No, they don't. And that's where things get tricky. Let's say a nurse notices a subtle change in a patient's condition and documents it, but doesn't escalate it to the attending physician. Maybe they think it's not urgent, or maybe they're hesitant to speak up. Hours later, the patient deteriorates, and suddenly, that one decision or lack of action becomes the focal point of a malpractice case.
And it's not just about what's in the record. It's also about what's missing. If there's no documentation showing that a concern was escalated, the assumption might be that it wasn't escalated at all. That absence can be just as damning as an actual mistake.
That's where the phrase, "if it's not documented, it didn't happen," comes from. It's a harsh reality, but it's one that healthcare providers have to deal with every day. Let's break this down a bit. What are some of the common pitfalls in ICU documentation that can lead to these kinds of issues?
Well, one big one is vague language. Phrases like "patient appears stable" or "condition improving" might seem fine in the moment, but they don't provide enough detail. What does stable actually mean? What specific observations led to that conclusion? Without that level of detail, it's hard to reconstruct what was really happening with the patient.
Another issue is timing. In the ICU, things can change rapidly. If there's a delay in documenting a critical change in a patient's condition or a delay in escalating that information to the right person, it can create confusion and, worse, lead to poor outcomes. And when those delays are scrutinized later, they can look like negligence, even if they weren't.
And then there's the issue of escalation itself. This is a big one. If a patient's condition is worsening, it's critical that the information gets escalated to the right person at the right time. But that doesn't always happen. And when it doesn't, the documentation, or lack of it, can become a key piece of evidence in a malpractice case.
Let's dig into that a bit more. Why do you think escalation doesn't happen as often as it should?
I think there are a lot of factors. Sometimes it's a matter of workload. ICU staff are often stretched thin, managing multiple critically ill patients at once. In that kind of environment, it's easy for something to slip through the cracks. Other times it might be a matter of judgment. A nurse might notice something concerning but decide it's not serious enough to bother the doctor about. And then there's the issue of hierarchy. In some cases, a nurse might hesitate to escalate a concern because they're worried about being dismissed or reprimanded.
That's such an important point. The culture of the healthcare team plays a huge role in whether or not concerns get escalated. If there's a lack of trust or open communication, it can create an environment where people are afraid to speak up.
Exactly. And that's where training and protocols come in. Hospitals need to have clear guidelines for when and how to escalate concerns. But they also need to foster a culture where team members feel empowered to speak up without fear of repercussions.
Right, and that brings us to the legal side of things. When a case goes to court, what's in the documentation or what's missing can be pivotal. Lawyers and expert witnesses will pore over those records, looking for any signs of negligence or gaps in care.
And it's not just about what was documented, it's also about how it was documented. For example, if there are inconsistencies or contradictions in the record, that can raise red flags. Or, if there are late entries that weren't properly labelled as such, it can create the appearance of impropriety even if there was none.
And let's not forget about the electronic health record systems. While they've streamlined a lot of things, they've also introduced new challenges. For instance, the way information is displayed or the way alerts are generated can impact how care is delivered and documented.
That's true. And those systems aren't perfect. There have been cases where critical alerts were missed because they were buried in a sea of less urgent notifications. That's another area where documentation and communication can break down.
So, what's the takeaway here? How can healthcare providers navigate these challenges and improve both patient care and their documentation practices?
I think it starts with education and training. Providers need to understand the importance of thorough, accurate documentation, not just for legal reasons, but for the sake of patient safety. They also need to be trained on how to use their electronic health record systems effectively.
Agreed. And beyond that, hospitals need to invest in creating a culture of safety and open communication. That means encouraging team members to speak up when they have concerns, and making sure there are clear protocols in place for escalating those concerns.
Absolutely. At the end of the day, it's about putting the patient first. Good documentation and communication aren't just about avoiding lawsuits. They're about ensuring that patients get the best possible care.
Well said. It's a complex issue, but one that's so important to get right. Thanks for unpacking this with me today.
Of course, it's been a great discussion, and I hope it sheds some light on an issue that doesn't always get the attention it deserves.
Definitely. Until next time. Thank you for listening to Lex Cura Clinical Insights. In an ICU case, no single note should be reviewed in isolation. The nursing assessments, vital sign trends, arterial line data, ventilator settings, laboratory results, medication administration record, provider orders, notification logs, rapid response documentation, and code records must be aligned into one continuous clinical timeline. The critical questions are whether the patient's deterioration was identifiable, whether the required monitoring occurred, whether changes were communicated promptly, and whether the response matched the urgency of the clinical findings. A gap in documentation does not automatically prove that care was not provided. But when that gap appears during a period of measurable deterioration and is followed by delayed intervention or a worsening outcome, it may expose a failure to recognize, communicate, or escalate. That is where the ICU record moves from technical documentation to litigation evidence. For more clinical intelligence, litigation analysis, and practical guidance, visit LexCura Summit at lexcurasummit.com. I'm Michelle Carroll. Thank you for joining me, and I'll see you in the next episode of LexCura Clinical Insights.